Morning to all the delegates who have made efforts to attend this very, very important IC on premium IOLs. As we all know, cataract surgery is the bread and butter, but there's a paradigm shift now. What we were trying to sell yesterday is being now demanded by the patients, and soon it will become the order of the day, where patients will say actually that they want EDOF IOLs or trifocals and things like that. So I'll be speaking on patient selection and counseling for the premium IOL implantations. And I'm very grateful to all my co-presenters who have come here early in the morning to be part of this IC, and very grateful to the audience also. So I have no financial interest in any of the lenses and products which are mentioned here. So there's a lot of advancements which is happening in the field of cornea especially. And there's also a lot of the advancement which is happening in intraocular lenses. Every day we are hearing of advancements in trifocals where they are trying to reduce the glare and halos. So the next 10 years we are going to see a lot of advancements, and so much so there's a lot of talk that we are not even sure whether the bag is the actual place where we are going to put the IOL in 10 years time, or we are going to put it back in the sulcus. There are a lot of talks and research going on. So a lot of advancement is going on. If you're actually planning that once my practice settles down and then I'll put premium IOLs, you have to think again. The future is now. And if you're sitting on the sidelines taking ages to decide whether to put premium IOLs because the patient expectation is so high, you are charging a premium. So actually you have to now come forward and deliver. So there's a beginning. You have to begin with the vision that I have to be doing these premium IOLs. It does require skill, instrumentation, and most of all, motivation is the most important part. In select patients, do the keratometry yourself. The goal should be that you have to have zero cylinder. Even if you are putting a monofocal IOL, you have to do your calculation such that you get a zero cylinder. Even if you are doing SICS, even if you are doing a regular cataract surgery, try to make a central round rexis, because one of the primary requirements, not absolutely this thing, but central round rexis is very important for the placement of these premium IOLs, because the central location is very important. Proper PC polishing is required, because we want to avoid future doing YAG capsulotomy in these premium IOLs because of issues of centration. And you have to prepare to invest in a good but not so costly biometer, and we actually mean that if you have a proper optical biometer for these premium IOLs, you'll be able to deliver to your patients even much better. So if you're, like I said, if you're waiting that I'll first settle my practice, I'll learn, and then I'll go and buy these premium biometries and high-end microscopes, it may be late by then. So premium intraocular lenses will soon become an integral part of your practice in ophthalmology. In fact, now I do not offer monofocal lenses to my patients. I either offer them EDOF or I offer them trifocal, depending upon the alpha and the comma. And if the patient is eligible, and most of them are now affording, most of them are now covered by the insurance companies. So you have to have, and it does not matter which location you are settled in. Some of the best eye hospitals in India itself are not in the biggest cities, they are in much smaller cities. So it does not matter where your location of the practice is, what is the size of your practice. And one of the top ophthalmologists in Ahmedabad, he hardly does 4 or 5 cataract surgeries per day, but he does only the top 5 premium IOLs per day and only 3 times a week. So it doesn't matter what is the size of your practice, and you do not necessarily have to be a high volume cataract surgeon. So you have to have some basic knowledge of what is a hydrophilic lens, hydrophobic lens, which is better, which gives lesser posterior capsular opacification, what is spherical and aspherical, what is apodized, refractive and diffractive IOLs, which all the company people will come and talk to you about. You have to have a knowledge of when do you need to put toric lenses, and in these trifocal and EDOF lenses, now the toric has also come. So the patient want to be glass independent free, so you have to put these toric IOLs. we are worrying more than the patient does. Actually, even when you are putting a monofocal also, the patient wants that they should be absolutely emetropic, and we are more worried of whether we will be able to deliver to the patient as much as the cost that we are demanding. The surgeon who is willing to spend some time educating the patients before or after the surgery is likely to have success. If you sit with the patients, tell them about a little bit about premium, glare and halos, they'll be more receptive. The next time, take a while to reassess your patient for who you would otherwise have suggested a monofocal IOL. There are a lot of Indian companies also which are making good trifocals and EDOF IOLs, and it's not necessarily that you have to go for these multinational companies. So pre-operative planning is very important, which will be covered by other speakers. You start by using one and you will slowly become more comfortable. The most important thing is that the entire staff should have the basic knowledge of premium IOLs. You are having a practice, you are in a hurry, you tell the patient you must put a EDOF lens or a trifocal, but the patient, as soon as they go out, they talk to your optometrist, they talk to your receptionist, कि doctor साहब ने ये बोला है, कैसा रहेगा? So everybody, right from your manager to counselor to everybody, and especially you have to now make a new cubicle in your private setup, which will be for the counseling, because when you are charging such a premium, you have to motivate the patient that this will happen only once in a lifetime and you have to go for the best lens. So for paucity of time, I'll just shift to premium IOLs may not be recommended in patients who have ocular surface disease. You have to be very careful with that. Fuchs dystrophy, monofocal IOL is, if it's there in the other eye, then you have to plan it properly. In pediatric patients, Dr. Love will be talking about that. In small pupil and fixed pupil, it sometimes becomes challenging. If there is a macular disease, you especially want to be very careful. Dr. Pooja Sinha will be talking more about retinal pathologies when you are planning for these premium IOLs. And some patients who have had previous refractive surgery. So astigmatism is very important that you have to take care. So now the only thing is that you have to tell the patients about ghosting, halos, glare and distance blur. So, and most importantly, after all this, you have to tell the patient that we cannot deliver you absolutely 100%. Sometimes we may fall short, and so it's very important that you give a consent form to them. Thank you so much for your patient hearing. Dr. Jayashree is here? Okay. So I'd like to invite Dr. Nilesh Mohan.
Yeah, second sequence.
Nilesh Mohan. जयश्री के बाद तुम्हारा है. So Professor Nilesh Mohan is a senior ophthalmologist at Regional Institute of Ophthalmology at IGIMS Patna, and he will be speaking on it boils down to accurate biometry, because this is the most important fact when you're putting premium IOLs. Dr. Nilesh Mohan, please.
Good morning, everyone. At the outset, I would really thank the Scientific Committee of All India Ophthalmic Society and APO and my chief instructor, Dr. Satyajit Sinha, for having me here. He had spoken about the use of premium lenses. So basically, this topic has been given because it really boils down to accurate biometry, because you are counseling the patient for premium lenses, and if you have drastic results or surprises, that's a concern. So why is it important? Because we are using premium lenses and the patient's expectation have gone high, and nowadays the cataract surgery is being done as a refractive cataract surgery. So the biometry, what do we do in that? It's a measurement of the corneal power, the axial length and other ocular parameters, and the IOL formulas to achieve emetropia. So in keratometry, we have options of manual, we had automated, we have optical biometers that do take keratometry readings, topography-based readings, and Schemflug imaging system-based readings. So keratometry should be done before any contact procedure done on the cornea as well as the axial length for both eyes. Now, various manual keratometers and various other automated keratometers also show different points, and basically you have to be consistent in using one of the keratometers to have a consistent result. The data validation is usually done if you have to remeasure. It's a standard teaching. If the K reading is less than 40 or more than 47, or the difference between the corneal cylinder is more than 1 diopter, or there is a difference in the corneal cylinder and the refraction cylinder, then you need to remeasure it. Now, the sources of error in keratometry could be an unfocused eyepiece, failure to calibrate, measurement off axis, patient not fixating, dry eye patients. These are all factors should be kept in mind while you're going for the readings. Now, coming to the excellent measurement. The standard is the ultrasound measurement. The contact procedure is the standard one, easier, cheaper. There are disadvantages associated with that. That can be rectified with the use of immersion, contact immersion. You will have more predictable results. And the optical one, which have come, you have different biometers, IOL Master 500, 700, Lenstar 900, and different biometers are there. They are definitely advantageous, more accurate, but very costly. And in hazy medias, it may cause an issue. But the newer biometers have taken care of these things. So principle of ultrasound biometry, you all know that there is a piezoelectric crystal. Usually there is an ultrasound velocity, the electrical signals, and are picked up, and various structures emit different signals, and you get a quality A scan. Now, you have an electronic amplification. You have a gate. You increase that when you are not able to visualize properly. Now, gates are basically electronic calipers for measurement between the spikes. When you have any doubts, you have to have correct measurement of the gates. Measurement, as I already told you, is based upon the ultrasonic velocity in different structures. The cornea is not routinely factors because it's too thin. Now, A-scan validation again is done if the measurement it has to be remeasured if your axial length is less than 22 or more than 25, or there is a difference between more than 0.3 in both eyes, or you have a problem with the fixation, or there is a difference in the refraction. So when a remeasurement is done, definitely it should be done without bias. One should not be knowing what error is coming. Now, in coming to the optical biometry, they are based on different principles: laser interferometry, partial coherence interferometry, and optical low coherence reflectometry. They use different biometers, use different technologies and the source. So this is a list of the biometers available, which are based upon different technologies: partial coherence interferometry, OLCR based, and swept source OCD based, and the use of those things. Now, comparison of IOL Master and Lenstar is shown in the picture. You can see that how the newer generation biometers are trying to be more accurate and measure different variables which are required for a more accurate IOL power calculation. Comparison of IOL 700 and Lenstar 900 have shown comparative results. Now, coming to the IOL formulas, we have different generation of IOL formulas available. First, second, third, fourth, and fifth generation formulas, we all know that. But recently, Cox et al. Suggested a new classification of IOL power formula based on method of calculating IOL power and data used for these calculations. This is historical or refraction-based, regression analysis-based, the SRK and SRK2. Vergence formula based on Gaussian optics, 2-variable Holiday 1, SRKT, hover Q, 3-variable Higgins, LEDAS, 5-variable, 7-variable, artificial intelligence-based, and ray tracing-based. So the parameters required for the calculation of important IOL power formula are shown in the picture. So which formula to use? So in all ranges, you can use Holiday, Olsen, Barrett, Universal, 2 Higgins, but 22 to 24.5, you have all modern formulas. Shorter axial length eyes, you require Hofer Q. Larger, you require Holiday. So, but Holiday 2, Olsen, Barrett's 2, and Higgins can be used in all segments. Minus power lenses, Higgins is the best to measure. In low powered plus lenses, SRKT, Hofer Q, Holiday 2, and Higgins is good. You have to be very careful in IOL power calculation in special situations like children, post-refractive surgery, silicone-filled eyes, and while implanting piggyback lenses. So these are the situations where you come to the newer generation formulas. They are more predictable. But despite all those things, why we need to optimize? Because there are different surgeons have different surgical technique. Others are using different biometers. Just 30 seconds. The size of the CC varies. There could be inadequate visco removal, capsular fibrosis, lens bag shift. So to conclude, I would say that we are still trying to achieve emetropia. The things are evolving. We have come to a stage where we are delivering very good results. Though the IOL powers are available in 0.5 step diopter steps. So I would say it's always the man behind the machine, how you're operating, how consistently you're using one machine and giving predictable results. So biometry definitely is very, very important when you are in the segment of premium IOLs. Thank you.
Thank you so much, Dr. Nilesh Mohan, for that wonderful presentation. One thing which I wanted to ask is the posterior keratometry, like in IOL Master 700, which is an upgradation from the 500. How important do you think it's absolutely for us to use in our day-to-day practice? Because we all know by now that posterior keratometry is important, but it's not very affordable by everybody. So how important is that role of IOL Master 700 for posterior keratometry?
It is, but when the comparison between IOL Master 700 and Lenstar 900 was there, the variables of effective lens position becomes more important.
Okay.
So that they have shown that ELP becomes a more important factor. So see, what I said is that when you are measuring more variables, you are calculating the IOL power with the modern formulas in a little more predictable way. That doesn't mean that if you are not having those, you are going to give a surprise all the time.
Mm-hmm. Okay.
We have a Barrett model which has a pre-calculation for this posterior corneal curvature, and they adjust the elements based on the other findings with the rule and against the rule. They have some adjustments. It assumes.
There is an assumption. Everywhere there is an assumption in all the formulas, but more accuracy is there in the Barrett's too.
There was a study.
इसको माइक को ऑन कर दीजिए. May I request Dr. Subhash Prasad sir and Dr. Nagendra Prasad to please join me on the chair here?
There was a study. They have measured the PCA, posterior corneal astigmatism, by 3 instruments: IOL Master 900, Pentacam, and one was. So they see that they are giving different results.
Yeah.
So predicted PCA value by Baylor nomogram, it is better in some cases. In some cases, measured is better. When refractive surgery is done, you can't predict. So then in that cases, measured, you have to take measured PCA. Otherwise, predicted PCA value, which is incorporated in the toric calculators, is sufficient. So they are using Baylor nomogram.
Thank you. We'll move. Dr. Professor Nilesh Mohan, can you please join us at the chair here? I'd like to request our next speaker, Dr. Vishal Kishore, who will be speaking on topo and tomography are important for premium IOLs. Dr. Pooja Sinha, can you please join us at the chair here?
Good morning. So coming to my talk on importance of topo and tomography in premium IOLs. Now in premium IOLs, such as toric IOLs, multifocals, EDOF, these has resulted in paradigm shift in the cataract surgery. Cataract surgery is now just not treating the disease. It's basically optimizing the refractive outcome as a refractive surgery. And the onus of giving a 100% result means patient expectation is very high, and onus lies on us as a refractive cataract surgeon. So what is topography and tomography? Topography basically measures the shape and optical property of the cornea, while tomography gives a 3-dimensional section of the cornea for the in-depth analysis. Now suppose if you're planning premium IOL, does the routine examination with slit lamp, detailed fundus examination with indirect microscopy and keratometry will suffice our preoperative assessment? The answer is big no. And especially in the era of refractive surgery, with premium IOLs in our armatorium, visual recovery after cataract surgery for eyes with irregular corneal astigmatism may not be as good as expected by surgeon and patients. So first we have to evaluate corneal irregular astigmatism and optical quality of cornea in patients undergoing cataract surgery. Then based on these findings, we have to give options to our patient for various premium IOLs available with us. So for this purpose, topography and tomography is important. So corneal topography basically helps in detecting ocular surface disorders, as myas are highly sensitive to irregularities of precorneal TFL, and ocular higher order aberration have indicated aqueous deficiency or evaporating eye disease for fluctuating vision quality. So even the American Society of Cataract and Refractive Surgery, they have proposed algorithm to diagnose and treat significant ocular surface disorders before any refractive surgeries. Apart from this, the size and location of pupils should be within normal range to avoid post-operative symptoms like halo, glare, and dysphotopsia, especially when we are planning IOL multifocal implantation. So coming to the evaluation in case of toric IOL. Now toric IOL corrects, we know it corrects corneal regular astigmatism, but it should be best avoided in keratoconus with significant irregular astigmatism. Now this is the first picture. This shows the symmetric bow tie appearance of a regular astigmatism. The other picture shows just the difference between regular astigmatism and irregular astigmatism. In the first picture, we can see again the typical symmetric bow tie appearance, while there is no symmetry in irregular astigmatism. Then anterior corneal astigmatism shifts from with the rule to against the rule as the age advances. So we are born with the rule and die against the rule. So what is this with the rule and against the rule? With the rule means the steep axis is at 90 degree, and against the rule, the steep axis is at the 180 degree. The picture down, the first one shows the what is with the rule, and this is a topographic representation. Now, posterior corneal astigmatism, on the other hand, remains against the rule in most of the cases. So nowadays, toric calculator like Barrett, they uses posterior corneal curvature evaluation, and this results in a lower prediction error in their calculation. But in future, direct measurement of corneal cylinder using anterior and posterior cylinder from tomography will be an alternate method where we won't be dependent on this with the rule and against the rule adjustments. Coming to the evaluation in case of aspheric IOL, we all know aspheric IOL is designed with a fixed amount of negative spherical aberration to compensate for average positive corneal aberration. But in eyes with LASIK or advanced surface ablation for myo, the cornea becomes oblate due to central flattening, and this results in increased aberration. So for these patients, aspheric IOL is a better option. While in case of keratoconus or LASIK for hyperope, there's decreased aberration. So for these patients, we have to give an option of spherical IOL, which is a better option. Higher order aberration increases with age, but in case of spherical aberration, there's not much significance, means no significant changes with the age. So ideally, topo and tomography assessment of higher order aberration before cataract surgery should be done, because aspherical IOL work best for eyes with average corneal spherical aberration without other forms of higher order aberrations. Coming to evaluation in case of multifocal or EDOF lenses, these lenses, especially the multifocal, they carry a risk of reduced contrast sensitivity, photopic phenomena, and increase in corneal high order aberration results in decreased contrast sensitivity. So topo and tomography plays an important role in detecting these high order aberrations and patient counseling for the implantation of these lenses. Now, after refractive surgery, we have to take a decision of which IOL is best, which is suited best for the patient. So again, topo and tomography comes into use because they identify myope and hyperope after refractive surgery in spite of its absent history. And it estimates optical zone, whether it's centered or decentered. And based on the corneal higher order aberration, whether low or high, we can do a proper counseling for the IOL implantation. So to summarize, means in our SOP of preoperative assessment, we have to even include this topo and tomography, and we can do in a 4-step. First is check for corneal irregular astigmatism. If corneal higher order aberrations are high, informed consent should be taken from the patient that poor visual recovery will be after surgery, and for these patients, multifocal IOL is a strict no. Then check for corneal shape after refractive surgery, confirm the surgical history from the patient, use correct IOL formula for post-refractive surgery, check for regular astigmatism, and finally check for corneal aberration, and then go for appropriate IOL planning. So this SOP should be included in our normal pre-operative assessment for the cataract patient. Thank you.
Thank you, Dr. Vishal, for that amazing, wonderful, comprehensive presentation. For paucity of time, we'll take questions in the end. We'll move on to the next speaker. Dr. Jayashree is now with us. She is the second speaker. She was the second speaker. She has come now. You have uploaded your? Okay. Dr. Jayashree ka laga dijiyega, second wala. And she'll be speaking on diagnosis and management of dry eye premium IOLs, which is very, very important when you're implanting premium IOLs in these patients. Dr. Jayashree, please.
Thank you, Dr. Satyajit. Thank you, everyone. And thank you for including me in this IC. My topic is diagnosis and management of dry eye before the premium IOL implantation. The number of cataract surgeries has grown significantly in the recent years because increasing lifespan, more of elderly population, and that's why we need a clear and precise vision after surgery to improve the quality of life of the patients. Now, diverse kind of premium IOL are used, and so the accuracy of IOL calculation becomes very important. Dry eye disease is a very common disease affecting millions of population worldwide, and this is characterized mainly by the tear film instability, hyperosmolarity, and inflammation of the ocular surface. Dry eye disease in cataract surgery is important because the dry eye gets aggravated after the cataract surgery, and if you treat the dry eye before the surgery, it optimizes the result. And important is that variability in the corneal power IOL measurement, that also varies if there is a dry eye, and that leads to errors. So cataract surgery in recent years has evolved from vision restoration surgery to a refractive surgery. And to achieve good outcomes, it is very important to have a minimum post-operative refractive error. So a stable tear film is very important because this is for accuracy and reproducibility of the corneal keratometric measurements, and dry eye disease has a very deleterious effect. The importance of taking the patient's ocular history is also emphasized, and dry eye is often associated with other systemic conditions, medications. Patient is having allergy, having diabetes, glaucoma, using glaucoma medications, contact lens wearers. So we have to take a detailed history, and evaluation of the ocular surface before this cataract surgery is very important routine procedure to be incorporated in our practice. So the latest definition of dry eye is, it is a multifactorial disease of the ocular surface, and it is characterized by loss of homeostasis of the tear film and accompanied by ocular symptoms in which the tear film instability is there, hyperosmolarity is there, and ocular surface damage and inflammation is there. Which now the dry eye you can broadly classify in the aqueous deficient and the evaporative type. The patient reporting to you may be asymptomatic or symptomatic with signs of surface disease, and then you can have aqueous deficient, evaporative, or mixed kind, and the management is to restore the hemostasis of the ocular surface. There are many risk factors, the more consistent among being the aging, female sex, mammalian gland disease, computer use, contact lens wear, pollutions, some medications. So comprehensive detailed history should be taken, including symptoms, medication history, systemic conditions, and there are designed questionnaires, dry eye questionnaires, which help you to diagnose and grade the dry eye. And if patient allows and time is there, pre-op you can take, or just simple leading questions in the history. Then evaluation, the most important being the non-invasive tear film breakup time, osmolarity, and the ocular surface staining. So you can divide the dry eye into different categories depending on these factors. The important thing being the tear film breakup time, which should be over 10 seconds in normal, the tear meniscus size, the staining, and then additional things, lid, conjunctival folds, and Shermer's test, and other tests if time allows. And slit lamp examination, a detailed slit lamp just to evaluate the corneal surface luster, punctate epithelial erosions, meniscus size, the hyperemia of the conjunctiva, and meibomianitis. So the most commonly we use is the tear film breakup time. The staining, using fluorescent stain and seeing the staining, how it looks under the cobalt blue filter, that gives you a aid in the diagnosis of the dry eye. The volume of the tear film, using the slit lamp beam, the lid parallel conjunctival folds, which should not be there, but if it is there, then depending on the number of folds, you have the grading. The inflammation, conjunctival, how much is conjunctival inflamed. The lid viper epithelial, the lid viper is the area of the upper and lower lid that wipes the tear film over the ocular surface, and you should carefully look at this area and see if there is inflammation and staining present. Mammography, blink analysis, this can be just seen while you are talking to the patient, taking the history. At least 10-15 blinks per minute should be there. Blepharitis, if it is present, that also can cause dry eye disease, and this is linked to the aqueous deficient dry eye. And then iatrogenic, due to some medications which the person may be using, some eye drops the patient may be using which has the preservatives like benzalkonium chloride, these can lead to the dry eye. And the systemic medications which often are responsible are NSAIDs like ibuprofen, many other drugs also, corticosteroids. Shermer's test to see the is a standard testing procedure, topography. And then coming to management, it is main at restoring the homeostasis using of artificial tears, educating the patient, modifying the environment, education regarding the any dietary modifications, and using the ocular lubricants and lid hygiene, warm compress. And if this is not adequate, then non-preserved ocular surface, the punctal occlusion, and if blepharitis is there, then topical antibiotic steroid or topical steroid, and anti-inflammatory like cyclosporin and liftigrast. I'll just take 1 minute more. So, osmoprotectants, trehalose, antioxidants, and preservative-free, lid hygiene, very important, lid scrubs, and anti-inflammatory, I already told, punctal plugs. And delaying, see, if the ocular surface is not stable, then we should delay the cataract surgery till it is stabilized. And in conclusion, I'd like to say, to ensure the optimal outcomes with premium IOLs, preoperative diagnosis and management of dry eye disease are crucial. This involves a thorough assessment including the patient history, slit lamp examination, and potentially tear film analysis, followed by tailored treatment to stabilize the ocular surface. Thank you.
Thank you so much, Dr. Jayashree. A wonderful presentation. Thank you so much. May I request Dr. Love also to please join us on the chair over here. In the meanwhile, I'd like to request Dr. Narendra Singh Verma to please present. And we would like to congratulate him. He got the ARC first prize for this same very topic. So congratulations, Dr. Narendra. And he'll be speaking on image-guided systems and toric IOLs. Dr. Narendra Singh Verma, please.
The outsider, and thank you, Sinha sir, for including me in his IC. So, image-guided system and toric IOLs. If we see the prevalence of astigmatism in cataract patient, about 26% of the patients, they are having astigmatism more than 1 diopters. So they are the best candidate for toric lens implantation. Out of every 3 or 4 patients, we can advise them for the toric lens implantation. So if it is not corrected, astigmatism is not corrected, in photopic condition, it causes double vision, blurry vision. In mesopic condition, it causes halos and glare and streaky lights. So if we see these are the potential source of error during toric lens implantation other than the non-toric IOL implantation. So we will deal with the preoperative, about the marking, how we can prevent the cyclotorsion error, how we will deal with the SIA, and intraoperative, how we can prevent the rotation of the toric lens. So which part of astigmatism is corrected by toric lens? We are able to measure anterior corneal astigmatism very precisely now. Then we have to measure the posterior corneal astigmatism, or we are using the predicted value based on the Baylor nomogram. Anterior and posterior will give you the total corneal astigmatism. When we are taking incision on the cornea, it will induce some SIA. So SIA with TK will give you the net corneal astigmatism, and toric lens are supposed to neutralize this net corneal astigmatism totally, then only we'll get the eumetropia. At present, we can measure anterior, but for the PCA, posterior corneal astigmatism, and SIA, still they are not measured precisely. So about the posterior corneal astigmatism, it is about 0.26 to 0.78. It is steeper vertically, so it is being a concave lens, it is inducing against the rule astigmatism. Dr. Douglas Koch gave us Baylor nomogram. This is the slide which everyone should know, remember, that when the anterior corneal astigmatism is with the rule, posterior is there, some amount of posterior is there which is against the rule, so the total is decreased, total astigmatism is decreased, so we have to correct with the rule astigmatism slightly lesser. And when it is against the rule, anterior corneal astigmatism is against the rule, posterior is adding into it, so the total is increased, we have to overcorrect, or we have to deal with ATR more, we have to overcorrect it. Then this type of, this is the Barrett toric calculator. We need not to calculate the posterior by the Baylor nomogram, it is incorporated in these type of calculators. This is, in the previous talk, it was told that in the young age, we are having anterior corneal astigmatism is with the rule, and as the time passes, it changes to against the rule. So we have, in the young patient, if they are having with the rule, we have to undercorrect it because it is going to change against the rule as the age advances. About the SIA. So SIA calculation, SIA measurement is not very precise. So Dr. Dr. Graham Barrett, his advice is that you have to try to minimize the SIA as much as possible. Go for the incision which is 2.4 millimeter or less than that, and use the SIA value 0.1 diopter. For incision which are more than 2.8 millimeter, use the SIA value 0.12 diopter. In individual cases, though it may be SIA may be 0.4 or 0.5, but the standard deviation is less. So in majority of the cases, you can use this value and it is working properly. If you want to calculate your centroid SIA, you have to go for the Dr. Warren Hill SIA calculator, or you can use our SIA calculator, which is better, which is easy to use, and you can scan this QR code. So this is our SIA calculator. So there are two methods for the markings. One is the manual marking method, second is markingless method. So in the manual marking method, you can use this bubble marker, pendulum marker. These are some digital markers, very costly, and these are electronic markers. They were used before the invent of the markerless system. They are based on the 3-step method, so there are chances of error. So to eliminate this error, a lot of doctors worldwide, they have invented some mobile apps. So the mobile app, they can eliminate the cyclotorsion error, but they can't eliminate the head tilt error. And there are two types in which the reference marking are required. In some reference marking are not required. So this is iToric error, and the iToric this app by Dr. Saurabh Patwardhan. So in this app, manual marking is required preoperatively. These are app by Toricam by Dr. Graham Barrett and Precision Toric app. These two apps, in this the manual marking is not required, because they are considering the limbal blood vessels for the marking. This is the Toric IOL axis marking app by Dr. Jetwa. This is by Dr. Sahil Chaudhary. So nowadays, we are having this markingless system. They are of Callisto, Varion, Aura, and on few are in the pipeline. This Aura is intraoperative marking. So after removing the cataract, you can, by aberrometry, you can measure the toricity and the spherical power. So these are the apps, intraoperative mark, this Aura and this image guided system. They can eliminate the head tilt error because they are measuring and they are marking at the same time. So they are a single step method. So I will show this. I will show you the some intraoperative tips. Just 1 minute waiting. Volume. Volume Volume is not there.
थोड़ा आवाज बढ़ा दीजिए.
नहीं, चालू ही नहीं हुआ इसमें.
नहीं, इसमें वॉल्यूम उधर प्ले कर दो क्या?
इधर भी जाके प्ले कर दो. वीडियो प्ले.
ठीक है, बिना साउंड के चला दीजिए. टाइम का ये.
अच्छा, कोई बात नहीं. So I will just tell. So the size of incision should be proper. If they are leaky incisions are there, then the lens can rotate. So then the CCC should be smaller and central. So if you are not having high-end instrument, you can use this marking method, marking on the cornea. This is also effective. The CCC will be central. Then the complete, you can hydro-implant the toric lens. If you are confident, it is very easy. Just there is initial glitch. Then you have to remove the viscoelastic from anterior and posterior surface. After removing, we have to nudge the lens on the posterior capsule slightly, so it will not rotate. Then don't overinflate the AC. If you are overinflate the AC, mainly in the myopic cases, it will rotate. Remove the speculum slowly. You should not decompress the anterior chamber, and use hydrophobic lenses acrylic lenses which are more stable. Thank you.
Thank you so much for your wonderful presentation. Thank you so much. It's so enlightening. I'd like to invite the next speaker, Dr. Subhash Prasad, who is a senior ophthalmologist at Patna, senior consultant at Dividrishti Eye Hospital, and he'll be speaking on EDOF and extended range of vision IOLs. Dr. Subhash Prasad.
Thank you, Dr. Satyajit, for including me in this this IC. The history of IOL dates back to 1949 when this gentleman just first implanted the intraocular lens, which was, since it was a first, so there was a lot of post-operative surprise. And as the age of the patients are advancing and the need for the near or intermediate visions are increasing, the most of the patients nowadays are they actually looking for the spectacle independence and intermediate vision for their daily activities apart from the excellent distance vision. And it was rightly coined some decade back by Lindstrom that the first complication of the intraocular lens is presbyopia. So modern day cataract surgery, the fundamental challenges are to provide a good vision for all distances, distance, intermediate and near, with the preservation of optical quality and reduction of the night vision problems. As we see the evolution of lenses, it was monofocal to start with, then the bifocal, then trifocal, and later on came the EDOF. But what was left was the unmet needs with the trifocal lenses, like the quality of vision, which was not as good as the monofocal vision. It had lot of problems. It has still, there are lenses which are trying to decrease the problems in the trifocal lenses, but there are still some, these are the problems which frequently encountered in multifocal lenses. So what was required was the EDOF lenses. That was the need of the day, that most of the patients, they wanted some intermediate vision without any night vision problem. So not all lenses which are claimed to be giving some intermediate visions are actually EDOF lenses. That they have to meet the certain criteria like NC criteria, which says that the depth of the focus should be more than 0.5 diopter, more than the monofocal lenses, and the distant corrected intermediate vision should be superior to a monofocal lenses. And nearly 50% of these patients should achieve 20/32 vision of the intermediate vision with the distant corrected vision, and it should not be inferior to monofocal lenses. So what the EDOF lenses do, that they create single elongated focal points to enhance the depth of focus, and since there is continuous focus, so there is no breakup of light, so vision is very good through the distance and in the intermediate, and with some workable near vision in some of the lenses. There is no loss of contrast, except that is said by all lenses, but there is definitely some loss of contrast in some of the lenses with the at least in these modern generations EDOF lenses which does not use this diffractive technology, there is no chances of halos and glare. So what are the types of EDOF? There are some monofocal EDOFs, not a true sense EDOF IOS like Enhance, Magnificent. And the first one which was actually approved by the FDA was Symphony lens. That was a diffractive IOLs at Lija. Then there are pinhole EDOFs IOLs, not very commonly used, based on the technology of spherical aberration like mini well. Then based on the technology of upfront shipping, that is prototype is VVT. And nowadays the refractive EDOF are picking up the market, and the prototype which has come is the Pure C from the Johnson & Johnson. So premium monofocals are also termed as enhanced monofocal, monofocal plus, smart monofocals, and the prototype lens which came into the market first was a Technic Enhance, which was able to give very good distance vision and some amount of in the intermediate vision. But the problem is that this is technically not a EDOF lens, and you can see in the defocus curve that it could give just 0.6 diopter of the depth of focus with this lens, which whereas in the monofocal you can achieve with 0.5 diopter of the defocus. Another one was the Vivinex, the Ray-1 lens, which is in a hydrophilic platform, which was actually designed by Barrett. Actually, there is change in the positive spherical aberration of the center of the lens, which causes the lens to behave in a way that it focuses for the intermediate vision and gives very good quality of vision because there is no diffractive ring, so the night vision problems are not there. This is the defocus curve. It can correct up to 1.5 diopter of the intermediate vision. Another one which is available in the market is Evolux. These are not true EDOF lenses, but they behave and they give good amount of near intermediate vision correction. Then coming to the diffractive EDOF, which was first implanted and we got the first FDA approved from the Johnson and Johnson was the prototype, and it was in vogue for so many years, but it has gone out of market because of the night vision problems, because it is based on the diffractive principles. So there was some problem with that. The another lens which is there in the market, not in perhaps not in India, is the small aperture or pinhole EDOF IOL. There is central optical area of 1.6 diameter, which actually 1.3 diameter, which actually allows only the focus ray of the light to go into the macula, and thus eliminating all other lights, so the patient gets some intermediate vision. But the problem is that as the pupil dilates in myopic conditions, there is very less amount of light going into the eye, so the quality of vision is not good in the dilated eye or in the myopic vision or scotopic vision. So it can be used only in the non-dominant eye, but it doesn't give that much good quality of vision. So another technology which was actually invented was the wavefront engineering technology, where the spherical aberration was induced only in the central part of the when induced only in the central part of the pupil, increases the depth of focus to overcome the presbyopia. So this technology was used in the lens where the spherical aberration is induced, and the one which is well known is the mini well lens. Here central within the central 3 meter or 3 millimeter of the lens, there is induction of positive and negative spherical aberration, which actually elongates the light and creates extended depth of focus, which can correct up to 1.5 diopter of the intermediate vision. Another one which is in the market is the wavefront shaping. We all know about the VVT lens from the Alcon. It's based on the X-wave technology. It has got some alteration in the anterior surface of the lenses, which actually stretches and shifts the wavefront, creating a good depth of vision for the intermediate vision. And there are some loss of contrast, but the company claims that it can give you as good as any monofocal lens, but there is some loss. But the patient quality vision is very good. Nearly all of the patients are very much satisfied, and you can see the binocular defocus curve. It is performing much better than any monofocal lens of AISO, the comparable counterpart, and it gives superior consistent visual acuity with all pupil sizes at all distances. The recently the new lens which Pure C has come from the Johnson & Johnson is the refractive type of EDOF lenses. This is the first purely refractive EDOF IOL from the Technis on the Technis IOL platform. The optical features of the Technis Pure C IOL include it has got the anterior aspheric surface like of Technis, but there is changes in the posterior surface with a modified refractive design that allows the consistent depth of focus extension from distance to near, with nearly no dysphotopsia as compared to any other trifocal lenses or some of the EDOF lenses, and maintains excellent vision, and there is much tolerance to any change in the refractive error in the patient with the surgery. So this is the you can see the defocus curve. And it claims that there is no dysphotopsia, and I have implanted in some patient, but my experiences are most with the VVT and many other lenses like Renner, but this lens also performs very well. And just to summarize, there is growing need of spectacle independence from the any intraocular lens implantation. Multifocal lenses are good, but they come at the cost of quality of vision. So EDOF lenses are a good choice, particularly in those where you cannot advise this trifocal lens, like those patients who do night of driving or have some compromised macular pathology. In those patients, we can go for the EDOF lenses. And the current generation of the spherical aberration induced refractive EDOF IOLs, there is no vision problem. So the EDOF lenses are going to the future of the lens implantation, and particularly the refractive design and those with the change in the anterior surface spherical aberration. These lenses are going to stay as far as the EDOF technology is considered. Thank you very much.
Thank you so much. So at least the basic take-home message is that if you are starting to use premium IOLs, start with EDOF and not with trifocals, because EDOF lenses are more forgiving. Thank you so much, Dr. Subhash Prasad sir. I'd like to invite the next speaker, Dr. Nagendra Prasad sir, who is a senior consultant at Buddha LASIK Center in Patna, and he'll be speaking on trifocal IOLs.
Thanks, Dr. Sajid, for giving me this opportunity. My topic is trifocal IOL. It was the Hofferke who was the first conceptualized the idea of multifocal IOL in 1982, when he noticed 50% discerned IOL having 6x6 vision and it was John Pierce was the first to implant bullseye type of multifocal IOLs in 1986. So multifocal eye is basically a single eye with two or more focal point and it different types like refractive and diffractive, and there is a combination of both the IOLs. Refractive IOLs for multifocal eye is not in vogue right now because it has annoying refractions and glare halos, and it is people size dependent, and it is very poorly tolerated by the people who loving outdoor works. Again, this is not in vogue right now. Now comes the this leads to the development of diffractive multifocal IOLs. First diffractive multifocal IOL was introduced in 3M called 3M diffractive IOL. It utilizes the principle of diffraction in conjunction with refraction. What is diffraction? A little bit. Diffraction is a slight bending of light as it passes around the edge of an object. The amount of bending depends upon the relative size of the wavelength of the light to the size of the opening. If the opening is much larger than the light wavelength, the bending will be almost unnoticeable. However, if the two are closer in size or equal, the amount of bending considerable and easily seen with the naked eye. This technology had been used in the diffractive technology IOLs. This is the picture of a diffractive optics of IOL, and this is basically a monofocal IOL, and diffractive element has been incorporated upon it. And this idea came with the Fresnel principle. Basically, it is a series of prism stacked upon each upon, and it bends the light to different focal point. Diffractive IOL, it is a addition. You can give the addition to the monofocal and diffractive element, and you can have a toric or for corneal astigmatism correction in the monofocal, and can cover under the addition diffractive element for the can cover the interior or total interior surface or total surface of the IOL. Since these lenses have diffractive optical effect at all point of lens, even if the pupil is eccentric or deformed, lenses will always supply power for distance near vision. These lenses are pupil independent. So there is no fear of having glare halo. The biggest disadvantage of putting in multifocal IOL is the appearance of perception of glare and halos and loss of contrast. Otherwise, all the patients can be implanted. So basically, okay, the spacing of the diffractive element controls the power, and the height controls the light energy split, and the adjusting the height of the diffractive element can split the light into different focal point. So since the width is just to provide the near vision, then if it is doubled, the first order power would be reduced by the half. So this gives the intermediate vision of 1.66 diopter. So in bifocal diffractive IOL, the 40% are non-deviated light, that is called zero order, which utilizes for the distance vision, and 40% deviated light, just is called order 1. It is utilized for the near vision. So there is a 20% light lost, and this 20% light loss has been utilized for the intermediate vision, that is called second order diffractions. So basically, trifocal combines the two different profiles so that vision will improve at all spectrum. In trifocal, second order light diffraction is effectively utilized to provide the intermediate vision. Thus, beside gaining intermediate vision, there is a less loss of defocus light, reducing the side effect of such as glare and reduced contrast sensitivity. Here you can see consider the two diffractive element with two power. First element for near and second for intermediate. You combine both together can give the intermediate vision like this. So now comes the question of who are not the suitable of trifocal patients who are not suitable trifocal IOL. Of course, the previous speaker have covered the topic very well, but for sake of completion, the airline pilot, truck drivers, taxi drivers, astronomers, patients whose job requires activity at night are not suitable for the trifocal IOL, and the patients suffering from the glaucoma, ARMD, diabetic retinopathy, too much demanding patient, and those patients who have unrealistic expectation about the trifocal IOL should not be implanted. Of course, the objective measurement is very important for implantation of multifocal. There is a very less share of market of multifocal IOLs But there are centers who have been implanting more than 90% of multifocal IOLs, because they are utilizing the chair time, and they are selecting the patient very well for the multifocal implantation. So objective measurement is very important. This is like large positive angle kappa, that is nowadays called CORD. It is the visual axis and pupillary center, between the difference between the visual axis and pupillary center. Normally it is 0.3 mm nasal to the pupillary center. Again, Dr. Vishal has highlighted the importance of higher order corneal wavefront for over the 6 mm zone. So this is the data. You have to have optical biometer for the obtaining this data. Here you can see that the Chang Wang cord is 0.3 mm, so it should not be more than 6. So here you can implant the IOL, of course, but in this case, in second case, this is again more than 0.6. So if you implant those patient having this multifocal IOL, may be appreciating more glare and haloge. Again, location of IOL is an ideal when it is centered in the visual axis and the pupil. That is called zero cord, but this is extremely rare and occurs when light reflex is dead center at the pupil. Then you implanting those cases, multifocal, there won't be any any problem with the multifocal IOL. But it is not the case. That optical most of the best compromise between the implanting the these two angle kappa, like pupillary center and angle kappa, you best compromise between your optical center, the lens center should come between these two. So if you implant this, if it is beyond that, then you have the light which is supposed to go through the lens center strikes upon the periphery and give annoying halos and glare. So again, the higher order RM root mean square wave front error for normal vision cornea is 0.38 plus minus 0.14 over 6 mm zone. If it is more than 0.5, it degrades the optical quality and have high risk of halo and glare, even if you have implanted selected the criteria of the angle kappa. So those patients experience glare. So corneal quality of the corneal clarity is very important for implantation. If you can incorporate this data into your practice, then it is going to have a very good result of all the multifocal IOLs. Now comparison of trifocal technology, it is already just a little bit. It is already in the market, and the best part is that this utilizes the light loss into different focus of point. So accurate barometry is preferable all the time, and you use optical or immersion, and you have to, if you have to astigmatism less than 0.7 for the non-toric IOL, trifocal IOL you can implant. And of course the well-centered capsulex is very important. Of course, so far the surgical technique is concerned, it is normal, you can use as routine and normal phacoemulsification in all the cases. So very meticulous patient selection, counseling and pre-operative workup to look for non-suitable candidates is key factor for successful trifocal IOL implantation. That way you can increase your practice of trifocal IOL by including more and more patients with freedom of glasses at all viewing distance. Thank you for your patience.
Thank you so much, sir, for that wonderful presentation. I'd like to request the next speaker, Dr. Pooja Sinha, who will be speaking on retinal evaluation before premium IOL implantation. Dr. Pooja Sinha is a senior VR surgeon at ABI Institute, Patna.
Good morning, everyone. I'm thankful to AIOS and Dr. Satyajit Sinha for this opportunity. So I'll be speaking on retinal evaluation before premium IOL implantation. As a retina expert, I advocate a thorough and complete fundus examination for all patients undergoing cataract surgery, let alone premium IOLs. But then again, with premium IOLs, as has been discussed, the stakes are high, a lot of cost is involved, and the patient's expectations are also high. Structures to be assessed are media, the optic disc, macula, retinal blood vessels, and general background. This is an important point. A posterior vitreous detachment has to be explained to the patient, because many a times after a very good cataract surgery with 6/6 vision and a good IOL implantation, the patient is very unhappy because he says that I see some floaters which are moving in front of my eye, which was not there before cataract surgery. So that can be explained because sometimes the lenticular opacity is so significant that the floaters are not appreciated. So in my practice, I write PVD, and in bracket I write explained, so that in future I remember that I have already told this to the patient. So fundus examination is important to prevent post-op complications. Cataract surgery, while generally safe, can sometimes lead to retinal complications like retinal detachment or a cystoid macular edema. Identifying pre-existing conditions allows for proactive management and potentially reduces the risk of these complications. Optimizing surgical planning. Certain retinal conditions might necessitate a modified surgical approach or even delay in surgery until the retinal condition is addressed, like so many disorders like diabetic retinopathy and so on. Ensuring best visual outcome. A healthy retina is crucial for achieving optimal visual outcomes after cataract surgery. Identifying and treating any underlying retinal issues before surgery can improve the chances of achieving the best possible vision. So how do we perform a retinal evaluation? So, first and foremost, a dilated fundus examination. This is a standard method where pupils are dilated with drops to allow a detailed view of the retina using an ophthalmoscope or a slit lamp. An OCT, this is a very, very important diagnostic tool. It is a non-invasive image technique that provides high-resolution cross-sectional images of the retina, allowing for detailed assessment of retinal layers and any abnormalities. Fundus fluorescein angiography sometimes has to be done. This involves injecting a dye into the bloodstream and using a special camera to visualize blood vessels in the retina, helping to identify conditions like diabetic retinopathy or a retinal vein occlusion. Ultrasound, if the view of the retina is obscured by a dense cataract, which is many times the case, an ultrasound imaging can be used to assess the retina. And then an A scan is also a type of measurement to measure the length of the eyeball, which is needed to calculate the correct power of the intraocular lens implanted during cataract surgery. So what do we look for when we do a retinal evaluation? The first and foremost, which definitely cannot be missed, is a retinal detachment, especially if there's just a peripheral pocket of fluid which can cause subsequent vision loss. Diabetic retinopathy, because many patients are diabetics and they come with the notion that when they see less, it is because of the cataract and nothing beyond that. And we have to explain to the patient that diabetic retinopathy, which involves the retina and the macula, can cause obscuration of the vision. A retinal vein occlusion is the blockage of the retinal vein, which could be central or it could be a branch. Macular degeneration, in age-related macular degeneration especially, damages the macula, the central part of the vision, which can cause vision loss and of course spoil a very well done cataract surgery. Cystoid macular edema is the swelling of the macula which can occur after cataract surgery and can be influenced by pre-existing retinal conditions. And any other retinal conditions like retinal holes, tears, hemorrhages, especially peripheral retinal holes in myopic patients, atrophic holes, large lattices with holes have to be addressed before the cataract surgery, because after cataract surgery, when the IOL is implanted, believe me, it is very difficult to do peripheral lattices because of the edge glare. So lattice has to be tackled before the cataract surgery. And foremost is patient education. Before cataract surgery, patients should be educated about the importance of retinal evaluation, potential risks and expected outcomes. So this is just for completion. Projection of light is sometimes used for retinal evaluation, which is important. And then you have the two light discrimination test for spatial or temporal differentiation. Entoptic visualization, which is nothing but perceiving floaters or any opacities inside the fundus or inside the vitreous humor. And then ultrasound I have already explained. When the media opacity is very significant, then we do a B scan. So these are just some OCT images which I had have captured, which were very subtle and could have been easily missed if we had not done an OCT. So in this picture you can see that there is posterior bowing of the outer retinal layers, and this can cause subtle abnormalities in how the patient perceives after cataract surgery. This is a very dense retinal lenticular haze which obscured the retinal findings, and when we did an OCT, I was surprised to see such a massive amount of intraretinal inflammation and fluid, which was immediately tackled before we underwent cataract surgery. So this is another case. You can see the subtle vitreomacular adhesion, which has to be very clearly explained to the patient and shown to the patient, because this vitreomacular adhesion can lead to a vitreomacular attraction, causing subsequent decrease in vision post cataract surgery. So this is a very important slide. I advocate OCT as a must for all the cases before cataract surgery, especially when we are putting premium IOLs. And I would say not only premium IOLs, any kind of retinal surgeries, and OCT is a must nowadays. It is a must pre-operative assessment before phaco surgery, because it helps to pick up subtle macular abnormalities. As I have already explained, patient expectations are especially high when premium IOLs are implanted. So OCT is a must in all cases, and we do that as a routine in all cases undergoing cataract surgery at our center. Except in hard cataracts and poor retinal visualization, OCT has to be performed in all cases. And in such cases, one should explain to the patient that once your cataract surgery is done, we are doing a B scan now, but once your cataract surgery is done and an IOL is in place, we will do a post-operative OCT evaluation to just complete everything in our armamentarium. Thank you so much for your patient hearing.
Thank you so much for the wonderful presentation, Dr. Pooja. I'd like to request the next speaker for today, management of residual refractive error. You have done a very good job. You have put a premium IOL, and then there's a refractive surprise. Dr. Love Kochgave, who is a senior ophthalmologist at Calcutta Trinetralaya, he'll be speaking on management of residual refractive error. Dr. Love, please.
Thank you, Dr. Satyajit, for the introduction and the opportunity. And the topic on which I would be speaking is management of residual refractive error after cataract surgery, and especially when we are using premium IOLs. So before we proceed, we should know the possible reasons for the refractive surprise, and some of the reasons which I have enumerated here is applanation tonometry before biometry. What we do at our center, that when the optometrist is doing workup and the child or the patient is having a cataract, we do the optical biometer first and then do the AT and then dilate. So that is one of the ways by which we can minimize errors. Dry eye, as we all know, is one of the potential and most common, I would say, the source of error. Poor fixation by patient during biometry, poor prior refractive procedure like classic PRK, and contact lens related corneal warpage. And for non-premium IOL category, silicone oil and posterior staphyloma are some sources of error. And one very important, though we sometimes don't give it that much of importance, is the typographical error, if it happens, or maybe clerical error, or by the doctor or the optometrist who is deciding the IOL. So setting up patient expectations is very important, because we should never overpromise. We should never tell the patient that it will guarantee spectacle freedom when we are doing premium IOLs. Always under promise. And what I generally say, that 90% of your distance and near may be possible without spectacles. Sometimes for 10% of your job you may need spectacles, so that dampens the unreasonable expectation by the patient, and when they get total spectacle freedom, they are delighted. So once it has happened, how do we identify the source of error? So in this, what we have to do is defer again glass appointment by 1 month after surgery, do a refraction again, dilated examination, recheck patient history, surgical records, formulas, IOL choice, repeat all the biometry, keratometry. Sometimes cystoid macular edema or some macular edema may be the cause of the refractive error. And if none of these are responsible, then assume that the error is due to effective lens position. So management can be either medical or surgical. In medical management, if the patient is satisfied, sometimes we are not satisfied, but the patient may be satisfied. So in those cases, just observe, don't tell anything. If the patient is unhappy but amenable to using spectacles after surgery, we can give them spectacles or contact lens if it is astigmatism or anisometropia, or if the patient is a previous contact lens user and not objecting to it. Surgical management can be either a LASIK or PRK, and these are the choice when the refractive error is less than 2 diopters. There is no corneal pathology, no photopic phenomena like glare, halos, and decreased contrast sensitivity. But when we are deciding about laser based procedure, we should wait for at least 3 months after cataract surgery before offering that. Next will be IOL exchange, and probably I would say this is one of the common surgeries performed in refractive surprise. And if the refractive error is more than 2 diopters, we know the source of the error, then we are sure that IOL exchange may give a better results. If there is a visual phenomena with premium IOL and you have waited long enough and the patient is not happy with it, we can offer IOL exchange. Technically, it is easier in the first 3-4 months, after which the fibrosis sets in the bag, and that we have already discussed in premium IOL exchange may increase the glare, halos, and decrease contrast sensitivity. So if it is a trifocal lens and we are going for a IOL exchange with another trifocal lens, we have to sensitize the patient that it may not solve the problem fully. IOL rotation is another choice in which if it is indicated in wrong IOL axis placement, but in late IOL rotation due to fibrosis of the capsular bag, it is better not to advise. Post-op astigmatism is the reference point for calculation, not the pre-op value, and there are various online resources. One is astigmatismfix.com, and second is developed by Dr. N.S. Verma, who was one of our instructors, and they have developed a very accurate online calculator for this. You can discuss with him after the session is over. And if it is a residual hyperopia, then piggyback IOL is one of the choice, and piggyback IOL when we select when we don't I know the IOL power that was implanted. Fibrous bag makes IOL exchange risky. AC depth is optimal, maybe 2.8, 2.9 or more. And if it is a hyperopic surprise, then the calculation is rough calculation will be 1.5 into the manifest spherical equivalent. And if it is myopia, 1.3 into SC. And there are various online resources also available for piggyback IOL power calculation. So with this theoretical part, I will just give 4 examples in which I have faced very severe, some severe, some not so severe problems of IOL surprise. When I was in the first year of my practice, I operated a 19-year-old, and the source of error was typographical. That time in Shankar Netralaya, we used to manually enter the values in their calculator and take a printout. And the person who was did a wrong entry, and we ended up with a -9 refractive error at glass appointment. So luckily parents were cooperative, they didn't create much problem. Next day we did a IOL exchange, and she got a good vision and is a happy patient, still following up almost 20 years later. Second was again in early days of practice, post RK. That time the newer machines were not available, and even I was not that well trained. So I ended up again this time with +9 at glass appointment. And this patient gave me a hell of a time, and they were from, I still remember, they were from Jamshedpur, but I got a call from Times of India, Bangalore. And they said, "Doctor, there has been this problem. I think there is a negligence from your side. We are planning to print this." So we got into panic mode. I immediately called our chairman. Then Dr. Badrinath called me immediately. "Doctor, what happened?" Sir, first thing, doctor, you should never talk to anyone in the press. Sir, I told, "Sir, I have not spoken. I am just informing you what was told." And he pulled his strings, and actually we searched the phone number on the internet, and that was of Times of India, Bangalore. So he pulled his strings with top management of the Times of India, and we were able to overcome this crisis. This patient went to Shankar Nethralaya, Chennai. They were offered piggyback IOL there, but eventually it lost to follow-up. But we came to know that somewhere else they got a piggyback IOL done in this case, though IOL exchange would have been a better option. Third encounter is one of the senior surgeons in our center, and he did a trifocal lens and it ended up with 0.75 diopter surprise. 2 months for 2 months he was bearing the son of the patient, because that he was stuck on one point, that I have paid a price of a premium IOL and I should not have 0.75, and he was giving hell to him. So finally 3 months later he roped me in and again 2-3 rounds of counseling I did. Then finally 4 months later son was insisting, was posted for IOL exchange that day. That day again I called him and I told that eye is of your mother. So for your value of your money, and if you're 4 months later you are going for IOL exchange of a trifocal with a trifocal, which we saw that it may not have that good result. You may have to bear more consequences. Finally, at that point, he broke down and didn't insist for IOL exchange and went for other eye trifocal lens, and which was a 0 power, and then the patient was happy. So this are some of the, and the last slide, this is the last slide. It is one of my own patient. She had come from US for surgery, and we gave, she opted for VVT lens, and we gave 0 power on the first eye. But 1 month, 2 months down the line, I came to know that she is not using spectacles for near, and almost 1.25 for near has to be used. She was not keen for near spectacle at all. So I aimed for minus 1.12, slight myopia in the other eye, but ended up with 0.75 with 0.5 cylinder. And now her unaided vision was 6.6 N10 in the better eye, which was 0 power, and 6.12 part and N8 in the other eye. But she was happy that she is able to see near without spectacles, and we ended up with a happy patient, though it was a case of a refractive surprise. So these are some of the situations of how to deal with, and we can have a discussion about it. Thank you so much.
Thank you very much. Can I quickly call all the speakers for a group photograph, please, because we have to give the hall to the next IC. Can I do that? Can I do that? Can I request Dr. Subhash Prasad sir to please give a memento to Dr. Jayashree Shekhar? Can I request Dr. Subhash Prasad sir to give a memento to Dr. Pooja Sinha? Can I request Dr. Nagendra Prasad sir to please give a memento to Dr. Vishal Kishore? I'd like to thank all the speakers and the audience who came early in the morning. Thank you very much.